Welcome to this symposium with Dr. Im and myself, me being Dr. Brian Harrisberg from Sydney, talking about the new IOL platforms for presbyopia correction. In particular, we'll be talking about the Liberty and the add-on multifocal lenses that are managed with EPS technology. The most recent ESCRS clinical survey in 2019 showed that there's a slow increase in utilization of these lenses, with 63% of premium lenses now being trifocal IOLs. The fact that the ESCRS study shows that 9% are premium lenses, of which at least 60% are multifocal IOLs, there is still some concern for surgeons and patients alike not to accept multifocal lenses. This goes back to the fact that these lenses create dysphotopsia and loss of contrast. The new EPS technology addresses these issues. We can see with the 7 rings located centrally in a 3mm zone, based on one diffractive structure, leaving most of the lens as a refractive surface, allows very good focusing for distance and near, creating exceptional acuities, but also reducing dysphotopsias and contrast loss. The EPS generates an intermediate zone through constructive interference. And on the left side, you can see the MTF peaks showing far, intermediate, and near good focus. And this compares to visual acuity data collected over 1, 2, and 5 years with equally good distance, intermediate, and near vision. If we look at light scatter using a Zmax optic study, obviously we're going to lose light through diffractive destruction. And as you can see, you will develop halos. The most important part is that when the light is well focused, it is for an extended area. However, you can also see that the 7 rings create halos, but much less than the 26 rings you would see in competitors' multifocals using 2 diffractive surfaces and many more rings. What is the benefit of this? Well, there'll be a higher contrast sensitivity and less overall dysphotopsia.
Thank you, Dr. Harrisberg, for your nice introduction of Liberty. Hello, my name is Dr. Im from Seoul, South Korea. I'd like to share you my Liberty experience. When I started the Liberty at the first year, I started with the 7%. But right next year, my Liberty expanded to 19%. Which is a fairly major part of my premium practice. This is typical Liberty implantation. It's very smooth. It has big haptic angle, and after removing the viscoelastic, I can see 7 diffractive rings in the center and the big 75 refractive zone outside. You can see clear 7 rings. Only 7 rings makes less light scattering. Let's see the design of Liberty. You can see the big haptic contact angle, which is one side 90 degrees and both sides 180 degrees, which is the largest one. I started Liberty with CTR combination because Liberty is hydrophilic IOL, but after several months of Liberty experience, I realized that there is a little refraction change after Liberty only. So I stopped using CTR. This study include 41 patients, both Liberty. I implanted the Liberty with mild to moderate cataract patients. after Liberty, patients distant, intermediate, near vision was fairly good, and almost all the patients had no spectacle use, and the majority of patients had low to little photic phenomena, and 0% had the severe photic phenomena. The overall, 90% of patients recommended Liberty to their friends and family, and 76% were very satisfied. There were occasional discomfort in 30%, but no one had regret. There is interesting slide. Even with over 1 diopter of astigmatism, the uncorrected distant visual acuity was fairly good. So this is comparable to monofocal IOL. In my practice, the counselor and patients select IOL in premium surgery. The counselor assessment is very important. So with the Liberty, the patient satisfaction were very high. There were less unsatisfied patients comparing to other premium IOLs. So patient referral rate were very high. So in my practice, the Liberty has major volume in premium IOLs.
Thank you, Dr. Im. In Australia, I've been a keen adapter of premium lenses and been using multifocal lenses for quite some time, and now EDOF lenses. So almost 50% of what I'm using is more of the premium style lenses and presbyopia correcting lenses. There are a cohort of patients who may not be comfortable with multifocal implants. They may not be able to neuroadapt after surgery, and you may be even able to predict this. There might also be a cohort of patients where there may be significant mismatch between expectation and what the IOL technology offers. Poor immediate outcomes based on residual refractive error will always result in unhappy patients. The challenges determining preferred working distance for the patient remain an ongoing issue, and patients change over time and they have greater expectations even after surgery. The late development of non-associated eye disease, such as macular disease, could preclude against multifocal IOLs. And I thought about this for a while and thought about the option of reversibility of trifocality or multifocal lenses. And thank God for Medicontur, who delivered the first Q add-on lens, which is a platform for the sulcus. So this means we can put a multifocal lens outside the bag. And the advantage of this lens is demonstrated here. There's almost no ciliary touch. It's a very stable, well-positioned lens. There's no iris capture. The convex concave optic will allow a distance separation from the in the bag lens, and it's fairly easy and safe to do when done correctly. Polished edges also offer the opportunity for no iris damage, stable intraocular pressures, and reversibility. This bottom diagram shows the 0.5 millimeter separation between the in-the-bag lens and the sulcus lens. So a group of patients looking for multifocal flexibility came about when I offered patients an opportunity for reversibility, and there certainly were a cohort, predominantly men, who felt that they would like the opportunity, if they're unsure, to reverse this operation by me removing the multifocal component, this being the first Q add-on. So this shows the technique of loading the lens, being sure to tuck all the haptics carefully, and closing with downward pressure on the optic, backfilling with viscoelastic, gently apply pressure, pull back, and then start to inject. Again, this can spring out. You've got to be very slow and careful. Aim for the iris or the sulcus. This is through a 2.4 millimeter wound. Then you can dial each haptic round without any downward pressure and allow centration. As you can see underneath is the toric lens, which did not move whilst the first Q add-on was inserted. The investigation I did was comparing the groups of the Liberties versus Liberty trifocal versus the dual procedures, where the add-on is the trifocal lens in the sulcus. The cohorts were very similar, mostly around about the ages of 60 to 70. You can see there was a predominance of dual lenses in the male sex distribution, and most of the patients were 2 diopters of astigmatism or less. The results were almost identical across all these cohorts. We can see on the left the trifocals, in the middle the trifocal toric, and on the right the dual lens implantation gave outcomes of almost 100%, more than 6/9 vision or 6/7.5 vision. The near vision was also identical across all these 3 cohorts, everyone getting N5 or J1 vision. The visual acuity is improved in all the groups. The residual refractive error was exceptionally small, and I based this on very careful diagnostics, IOL master data, new generation IOL formulae, and once the lenses are chosen, we get extremely good outcomes. The survey was done across the board, and it was very similar. Almost all patients are aware of some dysphotopsia, as it's impossible in diffractive lenses not to have dysphotopsia, but they were similar and very mild. The blue coloration mentions no complaints, and the orange color mentions glare inhaler, not bothersome, versus the other colors showing increasing difficulties. And when we questioned the patients according to lifestyle, again, it was the same outcome. It doesn't matter which lens system we use, we got similar and expected complaints of very mild glare and some driving vision issues, but it was graded between 1 and 5, and no one reached grade 2 except for some nighttime driving. All other social functions were regarded as not significant enough to complain about any issues. So in summary, these patients all become spectacle independent. They have far vision, intermediate vision, and near vision unaided. And when we looked at a scale of 1 to 10 for satisfaction, all the groups were extremely satisfied. And I could find no difference between the dual procedure versus the Liberty in the bag procedure. And at this moment in time, I've never removed an add-on trifocal lens from the sulcus. In summary, we have solutions for correcting presbyopia by 2 platforms using very similar technologies, with the Liberty having 7 rings and the add-on having 6 rings, with a predominant refractive surface and a 3 millimeter diffractive surface in the center. The elevated phase shift, or EPS, gives us the constructive interference to enable intermediate vision and gives us many more options for the future. Thank you all for your attention. Thank you, Dr. M.
Thank you.
And I'm very pleased to be part of this conference.